department for all the effort and hard work that they put in for the last few months in the issue of combating this virus. Chairperson, I think the citizens of the country is very fortunate that the minister can give them some updates from health on a daily basis, and I think we really need to highlight the issue that everybody in this government is doing everything in their power to assist us to combat this virus. This morning, we are fortunate to have the presentation from the Minister and the Department of Health on issues that that people in this country is asking questions and faced with, and also that we as the Select Committee and the Portfolio Committee this morning will have the opportunity to do our oversight work over this department. With that few words, Chairperson, I also want to ask the members of the Portfolio Committee and the Select Committee to give us an indication who are here. I can say that all members of the NCOP from the Select Committee are present, but I will allow them to just say greet them, and then after the Select Committee, I will ask the members of the Portfolio Committee in the National Assembly to also give us an indication of other. So I will start with a roll call from the NCOP. After the NCOP, the members of the Portfolio Committee can also just give us an indication who are present. And with that few words, Chairperson, I thank you. Can we start with the NCOP members who are present? Can you just give us an indication?
Nokuzola Ndongeni.
Morning, Chairperson.
Good morning, Chairperson. It's Elegant Chavelin.
Good morning, Chairperson. Ms. Lindile Luthuli, KZN.
Good morning, Chairperson.
It's Audrey Malika from Mpumalanga.
Morning, Chairperson. Nokuzola Ndongeni from Eastern Cape.
Good morning, it's Dalmain Christians from the Northern Cape.
Vice Member Baha.
Morning, Nonkili from Northwest.
Good morning, Chair. Mbulelo Baha from Gauteng.
Thank you. So all the members of the NCOP are present. Can we have the Portfolio Committee members to give us an indication who is present, please?
Good morning, Member van Staden is present.
Good morning, Honorable Ismail present.
Good morning, Anna Kela from Gauteng.
Good morning, Viewer Kwahube present.
Good morning, Naledi Shira from Gauteng present.
Jacob from Western Cape present.
Morning, I'm Eastern Cape present.
Good morning, Mariscus, Western Cape present.
Shaky Mom.
Good morning, it's Khani Hendricks, present.
Good morning. Is that all the members of the Portfolio Committee that has given indication that they are present?
Have you heard me, Chairperson Shaky Mom?
Yes, I did shake.
Thank you.
Is that member from
Chairperson,
Staden?
Chairperson, did you hear me? It's Hanif Hendricks.
I did hear you, Member Hendricks.
Thank you.
If the members of the portfolio committee has given indication that they are present, I want to move to the department. If all of the members of the portfolio committee has given indication that they are here, then I want to move to the department to give us an indication who is all present.
Good morning, Chairperson Sokacha. Have you heard me?
Yes, Member Sokacha, welcome.
Thank you.
Let's move to the department.
Good morning, Anbin Pillay here, Acting DG, National Department of Health.
Morning, Dr. Pillay. Is there colleagues of you here yet?
Yes, Chairperson, there are a few colleagues I see that are logged in. I think they can introduce themselves.
Good morning, Chairperson. This is Gail Andrews, National Department of Health.
Morning, Chair. It's Ian van der Merwe, CFO at National Health.
Thank you. Is there more from the department?
Good morning, Chair.
Dr.
This is
Pillay.
Morning,
Dr.
morning, all
Pillay.
Chair. Joe Khatla, PLO. The minister is still struggling to connect, but the IT guys from Parliament are assisting. I've just sent them his number.
Okay, thank you. We will wait on the minister. Is there more members from the department that is present, Dr. Pillay?
Chair, I don't
Chair.
see.
Good morning, Chair. It's Sibungubana, the Chief of Staff. I'd also like to tender an apology for the Deputy Minister. He had indicated he was part of the delegation that received the Cuban Medical Brigade last night, early hours of this morning. And he had indicated that he may not be able to join because they were only landing in the early hours of the morning.
Thank you. So is it, yeah, morning.
Morning, it's
Annelies.
Annelies Waksele from the National Department of Health.
Thank
Acting
you.
DDG Primary Health Care.
Thank you.
Good morning, Chair.
Yes.
I'm Valerie Rennie, Head of Corporate Services, National Health.
Welcome. Dr. Pillay, is that your delegation? Can we continue?
No, well, we don't have the minister here yet.
Yeah. I think I will hand over to the chairperson while we wait for the minister to join. Chairperson Lomo, I'll hand over to you now.
No,
Must we wait?
Honorable
Yes.
Thank you very much. Dr. Mkhize is leading a delegation of very powerful DDGs and DGs. So, and I spoke to Dr. Anban yesterday. We will do it the way we did it last time. We will have Dr. Anban start the presentation, and the minister will then take over when he joins.
Yes. I can't hear you. So what I will do, I will hand over
Yes,
to
there
Dr.
may be a
Pillay to take us through the presentation. Your sound is very, very bad. So Dr. Pillay, I will hand over to you to take us through the presentation. And then after the presentation, I think the minister will be with us, and then the minister can speak to us before we move on with the rest of the agenda. Thank you. I will hand over to Dr. Pillay.
Thank you, Chair. Chair, I don't know if you have a copy of the presentation.
We don't have access.
Dr. Pillay, I believe the
Dr. Pillay, we
presentation
will
was...
not have that copy as promised, because by 9 o'clock yesterday, I checked with you, there was no presentation as yet.
Okay.
So I think if our secretaries can just make sure that the presentation that will be delivered this morning be sent to all members. And then Dr. Pillay, if you can get your presentation on the screen, I think we can continue.
Chair, I'm not sure if you can see the presentation now.
It's not on my screen.
Not on your screen?
No, I can see you, Dr. Pillay. Good morning.
Oh, good morning. Let me try again.
It's not on my screen also, I can't see.
And now, Chair, can you see it?
No.
No? Okay, let me try once more.
Yeah. May I request that while Dr. Anpan is doing what he's doing, we also recognize and welcome our parliamentary staff that has actually helped us to put all this together. We also want to welcome the media. If the media also is joined us, we welcome you too.
There we go, Doc. We can see it now.
You can see it now. Okay.
Yes.
I think I'm also learning. Thank you very much. Good morning. If I can take you through some of the slides. So firstly, just to give you a sense of the spread of the infection globally, I think these numbers this morning have certainly exceeded the numbers here, but at the point at which we put these slides together, these were the numbers globally. I think we're close to 3 million now, much closer to 3 million than we were then, and closer to 200,000 deaths. So you'll see globally that we're looking at around plus minus 3% deaths overall, which is fairly significant. But there seems to be quite significant disparities in the death rates across countries. Some countries having lower than 1% and some countries much higher. I think trying to understand the reasons why there are differences in these mortality rates across countries is important for us to understand, so that we can plan for our own response in this regard. And then if you look at our COVID response relative to many of the countries within the region, which is the table on the right hand side, you have the total number of confirmed cases at the point we put this together. We have South Africa at 4,220, way above many of the other countries in our region, the DRC, Mauritius, Tanzania, and Madagascar being the closest, but much lower than what we are currently. So the SADC region has in total reported about 5,704 14 confirmed cases, and 140 fatalities. And this has largely been come through from South Africa. Egypt and Algeria on the continent are the other large contributors to the infection rate. This slide looks at the comparisons in both the cases and the death rates. The slide on the left basically provides the cases, and the slide on the right is related to the deaths. What you can see is that as per the previous table, that South Africa is way above many of the other countries. The closest comparator is Egypt and Algeria, who seem to have similar rates of cases to South Africa. What's interesting, though, is if you look on the right of that, is the deaths, and you see that Algeria and Egypt are still higher than South Africa when it comes to deaths. So we appear to be doing better on the deaths, but we clearly have more cases than they do. I think one of the lessons here is making sure that you're able to test and identify the cases early so that they can be managed much more quickly, and protecting those who are at risk. And then we have the DRC, Mauritius, etc. The curves you can see from many of the countries have appear to have flattened in this region. We need to see whether this is going to be sustained over time, or continue at the level that we're currently seeing it. These are global comparisons, and here you can see South Africa's doing much better relative to the global trend. The US is now the leading country with cases, followed by Spain and the UK, and then Iran and China. In terms of cases, which are on the left-hand side. On the right-hand side, you have the US. Hello.
So sorry to disturb. Sorry to disturb. Am I the only one who's not seeing Anpan and his presentation, or all other members can see the presentation as Anpan is doing it?
We can see it, so the problem might be on your side, Jefferson.
Yeah,
we
also
can see it.
No, we see it. It's clear.
No. If I'm the
Chairperson,
if I'm the only one, then that is fine.
okay,
We'll continue like that. Okay.
Okay.
I'm sorry, Chairperson. We'll see how we can fix that. Then the total confirmed deaths on the right-hand side, and you can see South Africa is still very low in terms of the number of deaths relative to many of the other countries that have significant mortality, well above the 1,000 mark in most cases, and I think that's the high burden of deaths across the world. Coming chair now to the APN surveillance data, the reported cases. This was as of the 26th. The numbers are change every day, and you can see that the total cumulative cases is 4,546 at the time, which is about a 4% increase in cases, so about 185 new cases. And the national case fatality rate is sitting at about 1.9. As of globally, it appears to be 30%, so we're still much lower on that score. And we can see that there are differences, nevertheless, in terms of that across the provinces on the number of deaths that we're seeing. Obviously, KwaZulu-Natal and Western Cape are the big numbers there, and then followed by the Eastern Cape. We need to follow this very carefully to understand how we deal with this case fatality and identifying those at risk. This is a graphic description again of the total cases, the daily new cases, and then the deaths as well. Clearly the hotspots in the country are the metros in Gauteng. That's the city of Johannesburg, the Ekurhuleni area, and then Swane, Mangaung in the Free State, and then eThekwini in KZN, Buffalo City and Nelson Mandela Bay in the Eastern Cape, and the city of Cape Town in the Western Cape. These appear to be the biggest drivers of the epidemic across the country. If we look at the cases and deaths since first reported, you can see the trend as it appears currently. The trend appears to have increased, although you'll notice at the point of the introduction of the lockdown that the curve took a turn as such, or a knuckle as it is called, and the number of cases or the rate of increase had reduced. We're hoping that this trend will continue, but we need to watch and see as to what other measures need to be put in place in order to bring the steepness of the curve down. This refers to the number of deaths since the first reported case. You can see the deaths appear to be at a fairly similar rate over the period since the first death, which was reported around the 26th of March. The number of new daily COVID cases as well as deaths. The top line shows you the number of new cases, and the bottom is the number of new deaths. You can see that the number of cases have been following a trend, but closer to about mid-April, there seems to be an uptick in the numbers. This may be largely linked to the testing and screening that is being done on a door-to-door basis, where we're trying to seek persons that may be positive but are unaware of their status, or have not sought medical care. Remember, prior to this, we've largely been operating on a passive system, where when one feels ill, they go in and are tested and are then identified as COVID positive. So clearly, when we go in and also look for positive cases, we will then find them clearly, and this will increase the numbers, and this to a large extent contributes to some of the increases in numbers that we've had. The deaths have been following an erratic trend. You can see on some days we have 12 deaths, and other days we just have 1 or 2. This largely is a function of the at-risk population and when they actually contract the disease. This is again a graphic depiction of that, broken down by provinces. The Eastern Cape is in green. Free State is in yellow, orange. Hopefully it's the same color on your screen. Gauteng is purple. KZN in blue. Limpopo, I'm not sure if you can call that olive. Mpumalanga green. Northwest is green as well. Northern Cape. And then there are some cases where when the lab samples are taken, people provide an incorrect province or don't provide the province, and this then results in an unclassified or an unknown group as such. And then the Western Cape. What we've seen over the past few days is a huge spike from the side of the Western Cape. Previously, Gauteng had been the province with the highest number of cases. This now has changed, and you can see that Western Cape seems to be having more cases, and something is driving that, which I'm sure our colleagues in Western Cape would be able to provide more detail within the next few days. In terms of laboratory services, the total number of tested at the point of this slide was 168,643, and those newly tested was 7,639. What you will see is that the number of tests that are being done in the public sector now exceeds that being done in the private sector. This is largely due to the fact that we're having a lot of door-to-door screening and are trying to identify people that are potentially positive and in the community itself. So this table provides you with the community screening and testing. The total tested is 22,906, which is about 14%. Passive case finding is people that actually come into a facility and ask for a test or come in with some illness and are tested. We see that these are the percentages and the numbers. So we still don't have a lot of people that are we finding that are potentially at risk. Remember, the screening involves firstly screening an individual for the potential risk that they have COVID through a symptomatic assessment, and thereafter they're referred in for a test. So we see in terms of the new tests that it's about 7,639, and the total again, as I said, 168,643. And the public sector clearly is now ramping up in terms of the number of tests that it's doing as the door-to-door numbers and households increase. The COVID tests that are being done by date are reflected in this graph. So these are the number of new cases that have increased despite a decline in the test volumes over the past few days. These are both the public and private set. The public is in the dark green, the private is in the dark green, the public in the light green, and then the cases are the line graph. And what you can see, the total number of cases by day obviously increases as the number of tests increase. You can see that in the left graph, and you kind of see a similar picture on the positivity rate. I think the point I made earlier is that even though we're increasing the number of tests, we're kind of seeing a positivity rate that is hovering around the 3% range. I mean, it goes slightly above that, slightly below that, but on average, it's in this line. So as we seem to increase the tests, doing the door-to-door, etc., it doesn't seem to be making a very big difference in the positivity rate, which kind of suggests that the community level spread is still at a low level relative to what it is in many other environments. The number of tests performed by date again are indicated here. Private in green, the public in orange, and the cumulative total is the blue line, which you can see the number of samples that are done. Again, just to give you a sense of the public and private tests, I suppose in the last few days you've seen that the NHLS has been really ramping up its tests as it gets more and more cases through the door-to-door screening. In terms of the community screening, as of the 24th of April, 5.8 million people have been screened nationally, with 41,000 that had been referred for testing. The case referral rate does differ by province. You can see that in the Western Cape, the rate is probably the highest, followed thereafter by the Northern Cape, and then the KZN and the Eastern Cape. So this is a very interesting trend in terms of the numbers that are screened and referred, which kind of aligns with the previous slide as well, around our overall positivity rate, which still seems to be fairly low, even though we're continuing to increase our levels of screening. In terms of contact tracing, as of the 25th of April, a total of 19,765 contacts have been identified through tracing, which shows an increase of about 8% if you look at that on the previous day. So the national coverage rate has increased from 89 to 91%, with the Eastern Cape around 87 and the Western Cape at 82. Contact tracing clearly a critical part of the work around prevention, as we identify the contacts to make sure that they remain in quarantine, as we determine their status, because they become the reservoirs of further infection in the community. In terms of hospitalization, you can see that nationally the total number of cases are 4,546, recoveries 1,637, deaths are 87. The cases are in the green bars, the recoveries are in the orange bars, and the yellow bars refer to the deaths. The provinces with the highest burden clearly have the highest number of cases, and the recoveries are looking very good in Gauteng as well as in KZN. In the Western Cape, this still seems to be lagging behind, and they have a massive case number relative to where they were, and I think that needs to be more clearly understood. The other provinces are doing fairly well relative to these three provinces. In terms of the hospitalization data, those that are hospitalized, isolated, in high care, ICU, etc., you can see that our ICU utilization rates are still fairly low. Those that are on ventilation as well, fairly low. Oxygen is in the green. If you see at the bottom is hospitalization. The orange is the isolation, high care in yellow. The darker green ICU, then ventilation, and then oxygen. And you can see across the provinces in general terms, there is not a high demand for high care currently, ICU ventilation or oxygen rates relative to when you would get into a surge period. So clearly this picture also seems to suggest our hospitals are currently not overwhelmed at this stage in terms of increases in the number of cases. In terms of quarantine sites, there are a total number of 288 quarantine sites. Not all of these sites are activated immediately, simply because the number of people that need to be put into quarantine may not meet the number of sites that we need. So we have clearly more sites than we need at this stage, but we have to keep them in wait. If we have an increase in the number of cases identified that need to be placed into quarantine, these are ready. We currently have 28.1% of our sites activated. You can see the provinces with the sites and the activation rate. In the Eastern Cape, for example, most of the sites are not activated yet, and so in the Free State as well. Quarantine beds, this basically goes into the detail of the number of beds. You can see we have 23,000 beds, and currently about 37% of those beds are being utilized. We're largely putting in people in quarantine who cannot self-quarantine. The other area where quarantine is being used quite widely is South Africans that are returning or repatriated. They get quarantined usually in the province where they arrive at, and so that's why you notice that Gauteng is so high, simply because most people come through the OR Tambo airport and they go directly into quarantine at a hotel there, and then the second province is the Western Cape. Some flights are going through there, and that's the reason for that. If I can then turn to the risk-adjusted strategy for economic activity, I think the President announced this recently, and then Minister Dlamini Zuma and Minister Patel announced the strategy, so I thought I should take you through the detail around that. Basically, I think the objective of our strategy is that if we do not take any measures, we know that this is the kind of curve we're going to get. This is the health system's capacity, and we need to then reduce the curve so that we remain within the capacity of the health system, and we do that by applying a number of measures that will reduce this. Our intention through the risk-adjusted strategy is to see how this curve does not exceed our capacity, at the same time bring on economic activity within that environment. I think it's important to emphasize in terms of economic activity that the pandemics itself will depress the economy public health interventions do not. And I think this is evidence from the 1918 Spanish flu epidemic. So from the Spanish flu epidemic, what has been very clear is that those economies that decided to move early in terms of restarting their economies without the infection rate in their countries being reduced significantly had a negative outcome from an economic perspective relative to others. So it's really critical that the economic activity waits for the public health intervention to achieve its full effect before the economic activity is started to any significant extent. You may know that the restrictions on the economy will need to be adapted, as I indicated, to the trends, and that this may require us to have a system of what we call an alert system that clearly allows us to relax or tighten the extent to which the economic activity can proceed. And so we are currently in the process of reviewing the comments linked to this alert system, which was released on Saturday. And the alert system basically has 5 levels. And these levels are largely dictated by the health status or the health response. So if the epidemic is increasing, then clearly we need to get to higher levels of alert, lower economic activity, and the converse is also true. So as the level of the epidemic reduces, we may increase the economic activity. So the alert system allows us to do that. This depicts this very clearly in the slide. You can see level 5 is a level where you have high virus spread or low readiness or capacity within the health system, followed by level 4, which is a moderate level spread. And then there is low level of readiness or capacity. Level 3 is also moderate spread, but with moderate readiness. The high readiness at level 2, and then low viral spread and high system readiness in terms of capacity. Our intention is to use this mechanism to classify provinces as well as districts, so that over time we would have a differential a response to the virus in terms of its spread and our readiness. So where there is low levels of spread and high capacity, we would be able to allow greater economic activity. As I pointed out earlier, the main epicenters of the virus appear to be in our metros across the country. So the key factors that we looked at in coming up with this alert system is the risk of transmission, that is the ease of implementing the mitigation strategies, the expected impact on the sector for continued lockdown, that includes prior vulnerability of the sector.
Dr.
Hello.
Pillay, me
Yes.
before continuing, let me just alert the meeting that the minister has joined us. And let me just welcome the minister in our meeting, and then you can continue. Thank you, Dr. Pillay.
Okay. Thank you. Morning, Minister.
Thank you, Chair. Thank you very much. Thank you. Please proceed. I'll come in at the end. Thank you.
Thank you. So the third factor is clearly the value of the sector to the economy, both in terms of its contribution to the GDP, the multiplier effect, and export earnings. Clearly, the main criteria that is the risk of transmission or the health factors, and thereafter the economic factors come into play. So the way this system was envisaged is my colleagues in the economic sector had gone through each of the different sectors, from manufacturing to wholesale and retail, agriculture, etc. Looked at the contribution that each sector has to the GDP, looked at the employment contribution, small and medium enterprises, the economic linkages, exposure, etc. Looked at these factors and classified industries within each of these various areas. and then went through to ask questions such as the proportion of the payroll that is likely to be paid at the end of the month, what is the risk related to retrenchments, the proportion of large firms in the industry, proportion of SMMEs, etc., and did a classification of this largely. And this slide gives you an illustrative example of how that was done. This is just an example. It's not the full piece of information. And this then was brought together in terms of the factors as I indicated, the key being the low transmission risk, being regulated and organized, where there's localized or low movement of people, and enabling other factors so that the economy can continue to operate. So coming to some of the restrictions that are that have been released as part of the levels, these restrictions will remain in place after the kind of national lockdown, and even if we're at level 4, these restrictions stay in place relating to sit-down restaurants and hotels, bars and shebeens, conference and convention centers, entertainment venues such as cinemas, theaters and concerts, sporting events, the religious, cultural, and social gatherings. No more than 10 persons outside the workplace permitted. The recommendation that everybody wears a cloth mask when they enter vehicles, and use this when they're outside of the home as well. The use of sanitizers, which has been in place for a while now. So the additional rules are that companies encourage their employees to adopt a work from home strategy where that is possible, and that staff try and work as remotely as much as they can, and where that's feasible. Employers need to look through how that can be done. Workers that are above 60, as well as those with comorbidity, should and negotiate with their employer to work from home, as this group has enjoyed higher risks of both morbidity and mortality from the data from other countries. Even if you look at our own mortality stats, a similar picture comes through. That there should be workplace protocols in place to monitor the disease and its spread. So when workers return, there should be screening, there should be testing continuously, because the workplace can certainly be one of the environments where the virus can spread. That would then lead to a widespread infection, much more than what we currently have. So that's one of the areas we need to monitor. We also need to encourage employees to wear cloth masks. The work environment should have sanitizers, and social distancing is important within the work environment. In addition to that, before any sector resumes, it's important that the health and safety protocols are in place, that the individual businesses and workplaces have a risk assessment plan in place, and to conduct health education with their employees. So it's not simply a case of employees just going back to work. They need to be educated about the risks of COVID, and various measures need to be in place within the workplace to prevent the spread of the infection in the workplace. That requires that the employer provides employees with sanitation, good ventilation, distancing in the environment, and making sure that they monitor the sick employees and ask them to remain at home, and having a system of reporting that, so that that can be monitored at a national level as well. So the proposal is that the levels of alert are 1 to 5. The National Command Council will make that determination upon a recommendation from the Minister of Health and the Minister of Trade and Industry. There will be a single national alert, as well as alert for provinces and even for districts at some point. This will be determined largely by the number of cases and the changes in the number of cases over time, as well as the capacity of the health system within the province and district to manage that. Where individual departments wish to expand their activities, they would consult with the Minister of Health to obtain directions as to whether the potential expansion poses any risk. A working committee will be established between both the Department of Health and the trade and industry, where the both ministers would look at the evidence linked to the risk of infection as well as the economic activity in a particular area. I thank you.
Thank you, Dr. Pillay, for that brief presentation. Members, I will hand over to Dr. Mkhize, our National Minister of Health, to give his input. Thank you.
Thank you very much. I hope I'm visible. I can sometimes not see whether I'm visible or not. But I want to just apologize. There's been quite a mix-up with the codes to get into the conference. So I couldn't get through for a while, but thank you for proceeding with the presentation. Let me then say that there are a number of other issues that were raised by the Portfolio Committee that we would probably want to touch on them. It might just be useful to get a sense from the committee whether we could do that straight away. Otherwise, I think what's important for now is that we wanted to just share the latest as to where we are in regards to the response to the outbreak. There are a few more things which we haven't gone into. For example, I'm sure you members would be aware at this point that we're seeing changes in the outbreak on a day-to-day basis. When we started, the Gauteng province was the one that had the highest, and things have shifted with now the Western Cape being the epicenter. The problem which we are seeing is that there's a changing pattern there. The pattern is that we have our outbreak, cluster outbreaks, which are happening in workplaces which were originally identified as essential services. So from the look of it, looks like we have to find additional support and to strengthen the response of the province into that area. Similarly, KZN has also been quite high, but we are now also concerned because the Free State, which was higher, has now been overtaken by the Eastern Cape. Now the pattern again is different, whereas in the Eastern Cape, in the Free State, the pattern was based on one incident where there was a church gathering where many people got infected from that. That has been contained because for the past few weeks now, the numbers have been kept stable around 110, 104 to just above 100. Then the Eastern Cape has shot up. Now, if you look at the Eastern Cape, the incident, the outbreak is driven by social gatherings, mainly funerals. And then, of course, it happened in the correctional services area. We had to put in reinforcements immediately there because this was located in an area which is densely populated, that is the correctional services. So we are now going to be looking at the distribution of the specialists coming from Cuba so that we can reinforce some of the places that we're dealing with. The other issue relates to what has been raised by Dr. Anpan Pillay in the presentation, and that is we are seeing increasing numbers from the public sector. That, excuse me, that is for us quite encouraging. However, we think there's still a long way to go, but our constraint is really more the supplies of our diagnostic kits that are taking a bit longer to get to the numbers that we're looking for. We do every day get explanations as to why there might be delays. So we have still not exceeded our capacity. In other words, we don't have specimens that are waiting to be tested just because of the shortage. We just want to be sure that we are ahead of the need. So we just mentioning that as a point was, as we move on, the past 2 weeks has actually assisted us to get more community screening to happen and more people to be taken into testing. So this we expect to continue for the next few months actually. And South Africa has really not done badly compared to the rest of the world. Many of the countries have not done as much as what we have done. But what we are happy about is that we are targeting now in the areas where there are problems. We nevertheless think that it's going to be important for us to keep a watch on the supplies of the diagnostic kits, because that's really where our challenges are going to come from. So having said so, I think that we would want to elaborate on some of the questions that have been raised by the portfolio committee. So you could probably guide us. If you would like us to deal with them now, those that have not been already touched, we can do so. But if you've got another plan, we can then look at it. Thank you very much.
Minister, I think, is Dr. Dlomo still there?
Yes, ma'am, I am.
Okay, well, you continue chairing now, Dr. Dlomo.
Yeah, thank you very much and welcome to the minister. We were alerted that you might be delayed, so we started with Dr. Anpan Pillay, who has assisted us with the presentation. I was going to that you continue with the questions that were raised, because we have agreed, maybe I don't know whether this was translated to the select committee, that we will not then bring new questions now, but that batch that we send, if you could do as much as you can. But because my chairperson Gillian maybe did not send her team questions, we could maybe take some of them and open a space for them, because I don't know whether they were able to send questions to you, Dr. Mkhize. If then that is, we can do it that way. For us, it would be clarity seeking, but not new questions that are going to come in from us for today.
Thank you, Chairperson Dr. Dlomo. I think let's allow the members of the NCOP to raise their questions. As you are aware, we had to leave one of our meetings very early because we were caught up in a lot of meetings. So I think let's allow the members of the NCOP, if there is any clarity seeking questions, they can raise it, and then the minister can once off answer, if we can agree on that, Chair.
So if I'm just trying to understand it, you're suggesting that we don't deal with the questions which have been asked, wait for the new ones and then answer all of them at the same time?
Yes, Doctor, because I think the NCOP members did not have the opportunity to ask the questions. Or maybe if it will be better if you can answer the questions that you received, because maybe there can be an overlap in the questioning. And then if there is still clarity seeking questions, then the NCOP members can come in. I think continue answering the questions that you received, Minister.
Okay.
Okay. Thank you very much. Let me start with the question that was raised that refers to the number of patients admitted and recovered from ICU and on ventilators. I assume that that would have come out because it's part of the slides that you would have tabled. And because it's a table, I would like to ask that acting DG can flight the slides and pick us that particular aspect of the slide, and then we can just go through it. In the meantime, I'll deal with the next question. The one question was whether the flu vaccines will help in the fight against coronavirus. The real response here is that we have got many different viruses, and there are different families. So the COVID-19 is a coronavirus, which is different to the viruses that tend to cause the flu, which is influenza viruses. Now, normally the flu vaccine would be a combination of strains of the influenza viruses, and so it does not have a direct impact on the immunity against the COVID-19. There's no kind of cross immunity across these two viruses. But what it does, it basically reduces the chances of people getting influenza infection as a flu, and therefore it actually reduces the level of morbidity or the heavy burden that would have been if the person would have had both the flu as well as COVID-19. So this basically saves people from the one type of viral infection, so that they might be facing one infection only. So that is really the benefits out of that. So it basically does not stop anyone getting coronavirus, but it actually does reduce the numbers of people who will have a flu. Because if we also remember that our flu, the influenza virus, tends to have a large number of people who are affected, and it's actually got a very high mortality. It's just that because we're used to it, we normally don't think of it as a major killer. At the moment, on record, the numbers of people who have been killed from the influenza virus tends to be much larger, and it's estimated that globally it's 300,000 to about 600,000. So it does become a pressure point if the two together were to come to the same individual. That's one of the things we're concerned with as we're going to winter, that we'll have two of these burdens coming at the same time. So that's the value of the flu vaccine would only come at that level. Then there was a third question that refers to people living indoors lacking vitamin D, and therefore the effect of coronavirus in the light of the fact that the scientists claim that the exposure to sunlight boosts immune system. I think this might probably be some elementary observation that people might be trying to make an association, but we don't have any randomized controlled studies that can prove that that is the case. So sunlight is good for you, fine, but that you can link it with coronavirus, it's not something that we've got evidence of. Then the next question is about communities with no water, no electricity, no food, no exposure to sunshine, living in a single room, no ventilation. How are they expected to fight coronavirus? Well, to start off with, people who are living under those conditions, it's really more because of the poverty that our country is experiencing. It's not so much that there's anyone who would be left into those areas by design. It's something that happens because communities and society and government can't cope with the pressure in terms of the levels of poverty. However, work has been done quite a bit. I don't have the figures here, but there's been a lot of focus, particularly from the National Coronavirus Command Council, to reach out to areas where there's shortage of water, to bring some water tanks and make them available to assist some of those communities. Every day we see the Minister of Water and Sanitation moving around trying to help to give attention to that issue, together with the local government, the various municipalities. So this becomes one of the areas where we are concerned about the fact that the shortage of water exacerbates the problem of sanitation, lack of sanitation or poor sanitation in the communities. The issues of electricity is the same. And of course, we know that in our informal settlement, this is one of the biggest issues. We do understand that there will be a bigger challenge in dealing with, for those communities to face the coronavirus, but in particular, the densely populated communities are going to be even more difficult to manage because of the fact that the numbers of people who get exposed from one person can be quite large, and isolation and treatment at home and quarantine becomes more difficult there. So we have had to bring in the aspect of getting quarantine sites where you can move people out of the congested areas so that they could be quarantined somewhere outside their own living environment, just to be able to help them through the period when they're supposed to be dealing with and fighting coronavirus. So that, I think, would be our response there. Then the next question is, when does the minister believe it will be safe for South Africans to resume normal life, given that we're approaching the winter season? Well, the presentation has put that quite clearly. We have decided on trying to classify the different areas. We don't think that the response or the return to normality will be all symmetrical and will happen at the same time. What it will mean is that there will be areas where you'll be quicker to return to normality. There are areas where we're going to be more measured in the way we're going about it. The President has called it risk-adjusted uplifting of the lockdown. That basically means that you see how we've classified the various levels. In this case, we are at a level where the level of preparedness is very low, as well as the level of transmission is very high. Now we have to move to a point where the level of preparedness is high and the level of transmission is lowest, and that goes through the 5 stages that have been highlighted. The question really is balancing out the various aspects, which is a return to normal activity versus a reduction of the risk of transmission of infection. Now, we already have that situation, which is very complex now. We designated food outlets as being the areas where we have essential services. We also designated the other areas, such as those involved in the health value chain, such as the production of medicine and so on. But that's exactly where we've had cluster outbreaks. In Cape Town, several ShopRite shops have actually been closed, and one GlaxoSmithKline factory also have had to be closed, with so many people that have been found to be positive. So we're going to find that it's not going to ever be a straightforward issue. So if in the one instance we would have understood that the rate of transmission is still very high, then we'll actually reduce the numbers of industries that must be started and be put in operation immediately. On the other hand, where we think that things are getting well and the transmission rate is low, and that the actual economic activities can be resumed, we'll move into that. But as soon as we start picking up the numbers going up, we are forced to actually close down some of those sites. I think the examples of the Western Cape has been is what's going to happen, and we must expect that there will be areas where we will say it looks like we can proceed with bringing up normal economic activities and open up various industries and transport routes and so on. But there will be areas where we might have to stop that and say, look, we thought this was safe, it's no longer safe, let's go back. So you will be having different areas where the approach is not going to be symmetrical. There will be areas where we might actually recommend that whilst the lockdown is uplifted, but in this particular area, there may not be, it might not be helpful to actually do so because of the level of transmission that we're seeing. So that is how we're going to have to face it. It's going to be, as we go along, we try and see what is the best for that particular time in the area. Then there was an issue raised about people forced to be in isolation in Limpopo and in Klerksdorp. Well, let me just say, in principle, we always classify people as having either, when they are positive, they will either be asymptomatic or mild to moderate, or they'll have a much more severe kind of infection. If they are asymptomatic, mild to moderate, then they don't need to be admitted in hospital. They can be treated in their own environment, in which case we expect that the doctors could then could assess the situation and then decide that the individual can be treated on home isolation, particularly if they're asymptomatic and mild and the conditions are such that they can do that in their own homes. But if we find that someone is serious, then of course they need to be treated in hospital. But we do make exceptions now where someone is mild or even asymptomatic but positive. At that point, it might become important to say, let's get them treated in hospital, even though they are mild, simply because they are causing infection and their environment where they live is such that it's not possible to treat them without getting them infected. We've already got cases here of people who were discharged from hospital when they were improved, but they'd gone back home and actually infected other members of the family, because being well and being capable of spreading infection are not the same thing. You can spread the infection even if you are well, and so some of the people will need to be kept in hospital because they can still spread the infection even if they are not feeling that they are symptomatic themselves. Then there are other areas where there are problems of cooperation between the patient and the within their environment, when it is felt that then the individual needs to be taken into a quarantine or a hospital isolation. So we have had this situation that has arisen in Limpopo, where the doctors were patients. There were two sides of the story here. On the one side, the doctors felt that they were well within their rights to be treated at home and so on, and they were not very serious. But then the Limpopo government had felt that there was a problem with the cooperation and certain information that was shared amongst them. However, we went into the matter, and after discussing with SAMA and the MECs, we actually then said that what was important is to try and get the doctors to make an evaluation as to whether there is a problem with the person at home. And then, of course, looks like there could have been some misunderstanding between the doctors and where their house assistant was and so on. But at the end of the day, the matter was taken up with I think SAMA took the matter up with with the legal teams, and ultimately the matter got resolved because the patient was removed, and the legal teams were actually discussing the issue as it were. I think it was unfortunate because in this case, what really becomes important is to try and find adequate understanding amongst all parties so that the process of treatment does not become a contentious issue. But there have been a few instances where we've had to involve legal systems to deal with the matter. Then, so in Limpopo, that matter was resolved at that level. In the case of Klerksdorp, again, the policy is not very different, but in this case, it would appear that the patient was taken to a designated ward, which was used to hold patients. They were waiting for the results, and that at the moment, they have 5 patients awaiting results that are also being treated for other medical conditions. So we don't have there any record of anyone who was forced into isolation. In the case of Limpopo, there was actually a court application that was made, and then the court granted that, and it went through. But it's a situation where I think if there are ways of avoiding those are the ones we need to avoid, particularly because the people that are involved are doctors who should be able to understand when there's proper discussion as to what should be happening. So as to what the situation is now, as far as we'll be concerned, that matter ultimately was resolved in Limpopo as well. Then there was a question raised about what about the facilities for quarantine. Now, I've got a table here which I can share, but basically what we are doing is that for all the provinces, we're looking for sites where we can make it possible for people to be taken out for quarantine because of their conditions. Densely populated areas will have it difficult to quarantine themselves at home. So in a number of instances now, people have been moved from their homes. So in total, we have about 8,832 beds across all the provinces, and the numbers of sites are 89. We can send that to the portfolio committee because it's just a table, so I don't think it's necessary to go through all of that. Then the other question was around facilities that have been assessed and are said to be compliant. Here again, we've got 310 facilities that have been identified with 23,598 beds. So this is to say we can actually absorb that number of people into beds. And our understanding is that if people are not sick at the same time, you can actually go quite a long way with those numbers without feeling the pressure of the overcrowding. Then the other question was the number of people admitted in hospitals. We need to provide clarity regarding the numbers in the private sector. That was already tabled. Every day we count how many patients are in the public and private. For a long time, we were having mostly the patients in the private sector, in the private hospitals. It's now changing, and I think the presentation that was done by the acting DG would be able to show us those numbers. But because the numbers change, I wouldn't read it now, but the last number that we had, I think as of about 24th, was 317 patients, 175 in public, 142 in private. Then it's broken down according to various provinces, although about 3 provinces did not have any patients whatsoever. Others had some in public and others had some in private. So we can share that as well. Then the next issue was when will we be using the Gene Expert equipment? In this case, we actually have started using the Gene Expert equipment. They've recently done some validations. The challenge here is that Gene Expert can be quicker, but the challenge here is that we have a limitation in the numbers of kits. At the moment, we've just received 10,000 kits, and those kits are going to be used largely. We've moved a lot of them to Cape Town, to Eastern Cape, KwaZulu-Natal, and Gauteng, and Bloemfontein. There will be another delivery of about another 15,000, which we expect from today onwards. And so we expect that they will also help to improve this capacity. But the Gene Expert kits are actually produced in the US. So since the US had put in a restriction on the stuff being exported, the other company is now operating out of Sweden. And so they've got some challenges that they've reported to us, and we are hoping that they will get over those challenges and then make themselves able to give us more. They've promised that they'll be increasing their supplies to us, but we are aware that the whole continent is also looking for the same kits, and so there's going to be quite a challenge as to whether they can cope with the demand from both our country and the rest of the continent. It's something that we'll see as we move along. But we are in touch together with the Africa CDC to look at how we can assist each other in this process. Then the next question was the availability of the PPEs. Now, I think the one way to explain this is that we do have PPEs, but what one has seen is that every now and again there's unevenness in the distribution. So you might find that in one district there is in certain hospitals and other areas we don't have. But there are also areas where we've got shortages. I was in the Eastern Cape last week, and our reports had been showing that they were still managing with their PPEs. And then when we looked at the report, and then when we got in there, we found that the doctors were presenting, started raising the concern about the PPEs, and the staff were feeling that they were being exposed. And we thought that's serious, because our record was indicating that they'd been on course in the supply. Then we found that, in fact, what they were now having were large numbers of stock that's being ordered but not delivered. And that becomes a problem, because there's a lot of price speculation out there. So if you wanted to buy at a certain price, suppliers move on to someone who can buy at a higher price. And so that has become one of the issues. We intervened immediately to make sure that we went into the stores where the stuff was being stored, and we actually moved some of the PPEs quickly to go and deal with the issue of Eastern Cape. However, we have also then gone into look at the private sector suppliers. I met with them and looked at the stocks that they have available. We actually still do have some stocks, but the level of commitment by the provinces means that sometimes they think they are waiting for an order. If it doesn't come, then they run short. So we now need to always have a much more active approach, where we'll say that the stock that is available somewhere stored must actually be distributed to the provinces which need it on that basis, irrespective of the fact that they might be waiting for an order where they've committed their funds from. So there must now be an easy way of withdrawing the money from an order that has not been delivered to purchase for immediate supplies. So we're going to be doing that now as we move on to make sure that we deal with this issue. In terms of the orders that have been put in place, the orders should be able to cover the next 6 or so weeks going forward. There is a process whereby the Solidarity Fund has come in to assist. I would say Solidarity Fund is operating more as a bridging finance to help the suppliers to procure the stuff, bring it into the country, and then once it's stored inside the country, then the provinces can then go and order, and then still the provinces have to pay for the stuff. So that whole mechanism, one has been trying to understand how it works. I think we just need an active management of that section so that we can deal with the orders and try and make sure that we don't run into supply problems. All we must be able to affirm is that no staff member, no professional, no health worker should be put in a situation where they must be going to see patients without being protected. That is not correct, and so we're going to be actively dealing with that. So as a result of that, when I found out that there was this challenge in the Eastern Cape, we actually got the manager in charge of the whole issue of procurement to work now personally on the various hospitals and check the stocks themselves, just to make sure that we've got the exact figure. So we do see that there's a problem in the way that the stuff is being ordered. So we're going to deal with that. We do have a table. Excuse me. We do have a table that gives the sense of requirements and stock at hand and so on. It does show that there's a lot that we still need to purchase. I can make that available as well to the members as it were. But we have also now formed what we call the Occupational Health and Safety Committees, which involve officials in the department, particularly the Commission on Occupational Health and Safety, together with the representatives of trade unions, as well as other academics and public and private sector representations. This team, we have actually assigned them the responsibility to raise the issues of safety of our health workers. And in so saying, they should feel free to be able to actually help us to audit the stock. So it's one thing what the manager will report, it's another what they will then report and check, and we will then act on the basis of that information. I think it's going to be very helpful to be able to deal with it that way. Then the question is around ventilators. Well, at the moment, we understand that we do have ventilators in the public and private sector. We haven't used so many yet, and so the question of future need, based on what we have seen in the US, in Spain, in Italy, and so on. So there have been companies in the country that are working with the Department of Trade and Industry, such as Ford, who have actually agreed to manufacture some of the ventilators for the needs of South Africa. We've also been talking to the clinicians to look at what needs to be done. And so we've actually been looking at the universities, gave an interesting proposal where they're working with some, I think Dell or some in the defense industry, a company that was manufacturing CPAP platforms. And we thought this was interesting, and so we've got our team to look into that, particularly because we believe that if it's manufactured inside the country, it's something that's going to be easy to achieve, to obtain. But secondly, the general discussion now is that there should be less agency or less rush towards putting people on intrusive ventilators, that we should start them on CPAPs. So if the trend continues, it allows us space to actually reach out to more people who will be covered with the CPAP equipment than they need the, the ventilator. It's a real matter of balancing the issues. So we're still working on that with our Ministerial Advisory Committee. The issue of mortuaries, readiness, and cemeteries. Here we've got some numbers, for example, that the mortuaries, cemeteries, and crematorium, we've got a capacity to deal with 36,000 storage facility for human remains. So the private sector undertakers have got about 28,000, but the government has got about 8,000. So what we are therefore looking at is that we're going to be engaging more of the players in this sector so that we can create even temporary capacity for storage. And I think this issue is one of those that we're going to have to look at very carefully, because it looks like we need to start encouraging communities not to store human remains for too long, even if that was not COVID related, so that we do not run short of space, particularly because once it's a funeral, it's a funeral. You don't want to have too many people. You don't want to keep a long time. We also don't want too much long contact with the human remains, as it were. So all of those are issues that we're going to be working on as we move along. We can also give a sense of the breakdown of all of these storage capacities. There's a table that deals with that. The other issue that was raised relates to the reports on vaccine against COVID-19. It is said that, firstly, let's start by saying that for a new infection such as this one, the only way of protecting the whole population is for the population to have what is called herd immunity. Now, there are three ways you get immunity as a human being. Either you get an infection and then your body develops antibodies, to fight the disease, and then those antibodies stay in your body. So every time that pathogen, whether virus or bacteria comes in, then of course they get attacked. Those are the immunoglobulins, IgM, IgG, which are really part of a normal immune response of the body. The other way is when the mother has given birth, and therefore through the breast milk, all the antibodies that they've got will be passed to the baby through the breast milk, and that's the IgA antibodies, which help to protect the baby so that when they are not familiar with all the viruses that the mother has got, they don't get sick as a result. The third one is a vaccine. Now, vaccine basically means that we have to introduce into the body a kind of agent that has got features of the offending virus, and the body responds to that, but the part that's been introduced in the body is not dangerous to cause an infection, and so you get immunity built that way. Now, that we need to go into that direction because there are not enough, there's not enough time to develop this immune system for everyone. So if we could have got a vaccine, that would have been useful. This is just to say that we do need the vaccine, and in the process of needing the vaccine, we need to be aware that before it is made available, there's got to be a lot of trials that have to be done. There are about 40 different vaccines that are being tried, they are being developed throughout the world. But 4 of them are progressing to a level where countries are at the phase 1 level of the trial. So that is UK, China, US, and Australia. And now the next phase, which should start in a matter of a couple of months, is the one where many countries are going to be participating. And we believe South Africa has to participate at that level because one, we've got adequate clinical and technical research expertise to be able to monitor that vaccine trial so that we've got the best kind of outcomes. It's a contribution towards the world knowledge around this particular disease. But at the same time, if you don't participate, it means that those countries that would have been in the forefront of the development of the vaccine through their trials would be the first ones to be able to get access to the vaccine, and therefore will actually be behind the curve, behind the end of the queue to get this. And we don't think we want to wait that long. We want to be amongst the first countries to be able to receive the vaccine when it's proven to be positive, to be successful. So from that point of view, we believe that we need to work together in that level. Now, I'm raising this point because I've seen that there were some comments that were made in the public media about vaccines, but actually, scientifically speaking, the vaccines are a correct thing to do, and the trials are done in such a way that they're no longer the kind of offensive trials that used to be done in some of the olden days where people would actually just go and do research, not caring about the human rights. All the research work that gets done now is mediated via ethical committees, and there's no ways some abuse can be accepted or tolerated in the case of some of the trials that we're talking about. Then the issue was one other issue was around the criteria for admission to the ICU. Basically, we have here guidance from the various intensive care and critical care society and specialists who would then give a broad guidance in terms of what criteria has to be used to take patients to the ICU. So we would say that largely we leave that to be in the guide of the specialists who deal with that particular issue. Somebody asked about whether there's likely to be another lockdown in the economy. Well, I think that question has been overtaken by events in the sense that the NCCC has now indicated that there will be a way of easing off, but it's not going to be just a once-off easing. It's going to be a staggered, risk-adjusted approach, and therefore, since that was tabled already, I won't spend too much time talking about that. The other question relating to the PPEs I'd already asked is almost the same question. And then somebody asked about bleach to use on clean surfaces. Well, all we can just say is that there are a number of disinfectants that are being used to clean the surfaces, and we encourage that people must use those to be able to deal with elimination of possible contamination coming from droplet infection on hard surfaces. And that's going to be one of the ways we're going to be dealing with issues going forward. Pelonomi reported that they didn't have sufficient PPEs. We can only just check. The last time we checked this, everyone, even in the province, they said there is a general challenge, but they have stock right now. So I think depends when you're counting and when the orders are coming through. I've raised the issue that we've got to be much closer in managing this issue as a department. Then there's a question about the call of foreign trained medical doctors to assist in the services. I would just say that at the moment we have actually approached China and Cuba to get those who are foreign trained doctors to come through. However, if we're talking about foreign trained doctors who are registered in South Africa, there shouldn't be a difficulty in getting them to assist when we've got posts available, and if we come in also either into those posts or they come in as volunteers. It becomes important to make sure that if you're going to use as doctors anyone who are trained as such, they must be registered by the HPCSA first before they can actually practice, because that way we can then be assured of the quality of their training and at least that they are suitable to actually work inside our country.
Honorable Minister, if you can allow me, please. We've got 20 minutes left of this meeting, and the chairperson of the portfolio committee do have a question to still pose, and myself on behalf of the NCOP. If maybe we can allow Dr. Dlomo. Thank you, Dr. Dlomo.
Thank you. We'll wait for the questions.
Okay. Honorable Minister, on the side here, I have been speaking to my members to maybe bring new follow-ups because, as you are rightly putting it, this is a moving target. So I have 4 questions that are collated from members, and Honorable Gillion is also going to come with 3 additional ones. I think you have covered well, and Honorable Van Staden was asking the issue of PPE as whether it is not creating a threat to our staff members. I'm sure you have said a mouthful on that, but if you want to say something more on that, you could. A question from Honorable Janji is to what is the rationale of allowing cigarettes to then start being available to South African citizens during this lockdown? The third one is to maybe we need to comment that the Gauteng, Limpopo, and Western Cape are showing good statistics on per districts. Now we don't see that in other provinces. What would be the reasons for that unevenness in terms of provision of information? The last one is that we would like a bit of another expansion on, is Eastern Cape really having big challenges? Have you said it all about challenges that you probably encountered in the Eastern Cape? Those are the 4 that came from our members and which are current issues that maybe you can assist with them. Then I hand it back to Honorable Gillian.
Yes. Thank you, Chairperson. Honorable Minister, I've got some questions from Pumalanga. It's the issue of the stats. Why it's taking so long? And then Member Maleka wants to refer the table provided in the breaking down into provinces. And see, the question is, in Mpumalanga, it states 4385 tested, 23 infected, 0 deaths, and 13 recoveries. So she really needs to know where is the 13 and from the 23 infected. Member Letuli, let me just get to Member Letuli's question. Member Baja's got a question. He's concerned about the Eastern Cape with regards to the incoherence approach and reporting on figures that are not synchronized with data in the NICD. How big is the problem? Member Letulu from KZN wants to know, can the minister and the department confirm how true is it that Addington Hospital in KZN has allegedly been hiding coronavirus infection rate? If so, what is being done about it? Can the department also assure us that all these people who are out there testing our people have been tested negative? Then only one concern from my side, Minister, is I'm getting a lot of messages from the people in the Western Cape to find out how is the national department going to assist the Western Cape, as the Western Cape has become the epicenter of the virus. And then the other one is the concern from parents about the reopening of schools, and how is the health department advising the Department of Basic Education and Higher Education and to deal with the opening of schools. Thank you, Minister.
Chairperson.
Do you still have a question?
Chairperson.
You can continue, Member Chabaleng.
Oh yeah, Chairperson. Thanks, Minister, for the brief, and most of my questions were answered in your brief. I just want to know. There've been lots of perceptions in the media and the social media about corruption. Are there incidences of corruption that you can tell us about? And if there were, what actions were taken, for instance, to remedy that and to ensure that whatever happens doesn't recur? My other questions about Limpopo were answered, but there is this, what was in the media yesterday about this person who died, who was in Cape Town, was driven from Cape Town to Limpopo, died at the hospital. But the people who were staying with this person in the house are said to be negative. What is happening? Is there any other information that we can give us that can help me understand this thing much better? Thanks.
Thank you, Member Chabaleng. Is Member Christian still there? Do you still have a question before I hand over to the Minister? Member Christian from Northern Cape.
Yes, thank you very much, Chairperson. I do have a question, and it is in regards to the referred cases in the Northern Cape, which are, the referred cases in the Northern Cape are very high, while the prevalence of actual cases are very low. So when will we receive the results of the cases that were referred to in the Northern Cape, so that we can have a true picture of what is actually the prevalence currently in the Northern Cape? And then just another question, as far as hand sanitizers and masks are concerned, what are the regulations around the wearing of these masks? Will masks be made available to our citizens, especially in workplaces, as obtaining one could be a problem for our general citizen out there? What workplace protocols are in place, and what will be our oversight role in checking whether workplaces actually adhere to these protocols? Thank you.
Thank you, Member Christians. Member Baha, very short.
Thank you, Chairperson. I think you've highlighted one question that I raised, which has to do with the Eastern Cape. That Eastern Cape, for instance, doesn't have a quarantine site, and the fact that of the incoherent approach and probably incorrect reporting in terms of figures. How severe is the problem and what interventions are in place? And the last one, Chairperson, is on testing. What is the turnaround time between testing and the pronouncement of results? Is there a backlog thereof, which could change the figures and reporting that we have if we have a backlog? Thank you, Chairperson.
Thank you, members. I will hand over immediately to the Minister. Time is running against us, members. Thank you, Minister.
Thank you very much. Let me try and be very brief, but some of the questions have been answered, have been asked a few times. I'm aware also that there are questions you asked which I have not answered, but if there's not enough time, probably that's all we can do. Let me deal with the question of the hand sanitizers and masks. We hope that the employers will be able to provide their employees with some of those. But masks, we're encouraging everyone to wear the mask in public places. And we say that from the point of view of the masks, the cloth masks are adequate. And so people can actually make their own masks. There's no government supply that's going to be made for people to get their masks. So we will want to encourage people to just organize their own masks. I've seen that already the public has started doing that. They've even made them fashion already. Workplace protocols, we're working on that. And so we will also, basically they refer to the basics, hand sanitizers, distancing, masks, and also the numbers of people that must be coming into work. They must be staggered so that they don't have a system that overwhelmed, but people must be screened so that people with symptoms don't have to come in. The case of someone who died in Cape Town and to Limpopo and so on, we were just checking a bit more information about that, but the simplest thing to say that if anybody is positive, does not mean that all those who are around that person may be positive at the same time. They can actually be negative. They need to be observed for 14 days. If they don't develop symptoms, then you take them as not having been infected. If they develop symptoms, then of course you have to treat them as such. And so they need to be quarantined and be observed over a period. There are no new specific cases of corruption that are related to anything to do with COVID-19, but we have our basic approaches to fighting corruption, and that is investigating and also using all the platforms we have to deal with corruption, but there's nothing specific to the COVID-19. The question around the Northern Cape, the results tend to come in pretty quickly. The only delay might be the transportation that might cause a delay with the people not with the hospitals being far apart, and therefore it takes a while. I haven't checked how long it takes because of the vastness of Northern Cape. There could be that problem, but it shouldn't be a problem that takes too long, because once the specimens are done, we are able to get the results very quickly. In the case of the turnaround time that's been asked, we don't have a backlog. About 3 weeks ago, we had some backlog, but now if we pick up a backlog in the system, we are able to get the public sector to take over and do a lot of those specimens from the private sector and eliminate the backlog. So we don't have a problem now. So when we report now, when we say 8,000 tests were done, they were done in 24 hours. And so we do that quite rapidly now because of our capacity. In the past, it used to take a couple of days and a couple of hours, but it's much shorter now. The reporting times are a bit of a challenge. When I report the results, I report up till 12 midnight, 1 minute past 12 midnight the night before, because we use the day to get the reconciliation, to clean up the numbers, check who's been duplicated, who's done two tests, 3 tests, and so on, so that we don't report numbers that keep moving up and down. So that's what tends to delay the time. But we do have a system that actually tells us immediately how many tests have been done. But that system can tell us up to right now, as I'm talking to you, I can tell you now how many tests have been done, but it's not verified, so it needs to be validated. If you want to announce those figures, you will see that afterwards what the team will do, they'll look at the numbers and then they start shifting people from this province to the other when they get the correct addresses, because sometimes people shift and change where they are and all of that. So that's back office work that gets done. That's what takes us a bit of a while before we announce the figures. We normally do that work behind the scenes. Then the question around the question around how we will assist the Western Cape. I've been in contact with the MEC of now. I've visited the Western Cape before. We're going to be visiting again. We're going to be increasing the numbers of kits that are going to the Western Cape. We're going to also be working very closely with the clinicians who are treating the patients to see what assistance they need. We'll be checking their PPEs. We also want to reinforce and put additional doctors, including those coming from Cuba, and we send them some more specialists, epidemiologists, and so on, where we think that there's a shortage. We're also going to work with them on planning, because I was discussing now with the MEC, we need to break down Cape Town into small blocks. Khayelitsha is one block, Philippi another block, and all of these, so that you can have a concentrated approach because of the large numbers of people that are involved at that level. Now, we normally test people on the basis of the symptoms. So any one of our staff who's got symptoms will not be taken into the field, and so we will then test them if they show any symptoms. The schools, opening of the schools, there's a phased approach to opening the schools. But just for members to know, the risk to children is not as strong insofar as contracting the infection. It's not so much the problem of the children, it's more the problem of how they will infect their own parents or maybe grandparents when they come back. So that's what we're really trying to look out for. Addington, we're investigating the issue of Addington, but as far as we are aware, it's not possible for a hospital to just hide people who are positive. We just need to, every time we get any alert, we then go and check and test what's happening in that particular hospital. In the Eastern Cape, I raised the question of the figures, and I said that considering the numbers of deaths that we are seeing, it is likely that if we do more testing, we'll discover more people, and therefore the figures would then probably be matched at that level. So that's why we reinforced and sent more testing mobile vehicles, as well as also as experts to go and assist and support them with PPEs and so on. That was because we need to make sure that the testing is done in a way that is solving the problem, and it goes to the areas where there are suspicions of where the infection should be, and then make sure that you can take people and quarantine them immediately. I'm not sure about this issue of no quarantine site in the Eastern Cape. When I was in PE talking to the MEC, we were able to immediately get about 800 beds in Nelson Mandela University to move people from their homes at KwaZulu, KwaDwesi, into that area, so that you can be removed from the area where there was infection. So that I would say is not really that they have a problem with treatment. In Mpumalanga, most of the people there in Mpumalanga have recovered. I think we've counted about 7 who might still be awaiting. Even those will probably be discharged in a matter of a few days. So I think there's less problems in Mpumalanga, but everyone must still remain alert. There is a challenge in the Eastern Cape. There were shortages of staff. We had to actually assign a TDG to stay in the district of Nelson Mandela Metro, and then we'd also fast-track the issue of the appointment of the chief director in charge. We'd also to give them authority to appoint as many doctors and nurses and close the vacancies that had been existing there for a long time. We are getting daily reports now. It looks like there's some work that's the work that's being done is actually quite promising. The numbers are increasing, but we have to actually focus on how do we ultimately contain the spread, and that's the focus that we're dealing with. The stats per district, we're going to try and synchronize this arrangement because we normally just give the provincial numbers. We leave it to the provincial totals. We leave it to the provincial teams to actually break it down to various districts. As far as I'm aware, most of the provinces are able to do that because when they give us the reports, they are actually broken down into various districts. And so it's probably a matter of making sure that they take it into the public. Rationale for cigarettes in the lockdown, well, I think that various other considerations would have been taken into account, but we can't debate the issue of cigarettes. Insofar as the health benefits are concerned, there are none for cigarettes. And cigarettes, as far as I know, and I'm sure Dr. Jantri knows, we can indicate to you all the side effects of smoking from the cardiovascular system, pulmonary system, causation of diseases, cancers of the lung, and peripheral vasculopathy, a whole lot of issues, that are caused by cigarettes. So there's not much you can say about the benefit of cigarettes on health, and that's it as far as I would be concerned. Then the issue of PPEs as a threat to members, I think that matter we were all similarly concerned, and we'll do whatever we can to make sure that our people have got the necessary protection, or insofar as the PPEs are concerned. I can still continue if you'd like, Madam Chair, but let me hold it at that on the question that you asked just now. That's where I would like to leave it. Thank you.
Chair, maybe just to add on to what the minister said specifically in relation to KZN, the MEC for KZN has just responded because she's picked up the question in relation to Eddington Hospital, whether KZN has been hiding the COVID-19 infections. She's asked that we clarified that that is definitely not the case. The first infected case was a nurse whose husband was employed at St. Augustine and was infected there. And as soon as the nurse tested positive, the matter was reported and the hospital CEO addressed the staff to inform them, and they immediately traced the contacts of the nurse who were also tested. In relation to the Limpopo question, yes, the deceased patient had moved from the Western Cape to Limpopo and tested positive and then passed on. The contacts, there were 15 contacts that were traced who were also tested, and they all tested negative. Thank you, Chair.
Thank you very much. I would like to hand over to Dr. Glovo, the chairperson of the portfolio, to just do the closing remarks of the meeting. Thank you, Doctor. Over to you.
No, thank you very much for my co-chair, Honorable Gillian. Thanks to the minister and the delegation of the minister that came along. I would encourage our members to continue sending us some of the information that they will need to clarity on, as we are aware that this is a moving program and we are grateful about the questions that have been asked. We would really want to end the meeting here now. Sorry to those members who started sending me some of their questions late, but we will all collate them and send it to the minister. Thank you very much, Minister, for the wonderful work that you continue to do. And thanks for bringing so many of the Cuban doctors to our country to assist and fight on. And for me, that is the last to speak, and is the last comment for me. And then I'll ask my dear colleague to close the meeting, Comrade Leon.
Thank you, Chairperson. Let me also take the opportunity to thank the Minister and his department for making time this morning to come before the portfolio and the select committee and to come and answer and clarify questions that we have put through to you. That is some concerns from the larger community in the country. Let me also thank all the members from both houses that we could have fit in our program to have this meeting. Thank you to all the staff members and the committee secretaries who has worked very hard to put this meeting together. I thank you. The meeting is adjourned.
Thank you, Chair.